Welcome to Northwestern Specialists in Plastic Surgery. We've created this informative presentation to provide you with information regarding breast reconstruction. Any and all of this information can be reviewed with any of our clinicians at any time. We hope this will simply provide you with some exposure to the process so you will feel more comfortable and informed as we navigate this process together. The three most commonly performed surgeries for breast reconstruction are tissue expander implants, Latissimus flap with or without an implant, and abdominal tissue reconstruction, including the SIEA, DIEP, and muscle-sparing free tram flaps. The Latissimus flap and abdominal tissue flaps are considered tissue reconstruction because they use tissue from your own body for reconstruction. Depending on your reconstruction needs and your personal preferences, we may use one or more of these procedures to produce your desired outcome. This chart will be provided to you during your initial consultation with us, so don't feel the need to read it all now. But it can be a useful tool in providing some overall information about the three most commonly performed types of breast reconstruction. As you move from left to right on this chart, surgeries become more involved, including the need for additional scars, additional hospital time, and longer recoveries. Also, as you move from left to right on the chart, reconstructions become more natural in appearance and less likely to require surgery for symmetry on the unaffected breasts in order to optimize symmetry. Tissue expander reconstruction is carried out using the same incision created by your mastectomy. This type of reconstruction is usually approached with a two-stage process. The first stage is completed at the same time as your mastectomy. After the mastectomy is complete, your plastic surgeon will place a tissue expander under the muscle on your chest, fill it to take up your excess skin, and then close the incision. After the first stage surgery is completed and you have healed, the tissue expander can be accessed with a needle to change the size. This is called expansion. Expansion is performed in the office once per week until you reach your desired size. Once completed, we will perform your second stage surgery, at which time the expander will be removed and your permanent implant will be placed. Small revisions to improve symmetry can also be performed at this second surgery. You may choose a saline or silicone implant depending on your preferences. Latissimus flap breast reconstruction involves moving a muscle and some skin from your back to your chest. This muscle stays connected to its blood supply under the arm. After this surgery, you will have a scar that runs mostly horizontal along half of your back and a patch of skin on your chest, which is skin from your back. This type of reconstruction is usually done with a tissue expander. Bringing tissue from your back creates a slightly more natural appearing reconstruction. This surgery is most frequently done when someone has had radiation therapy in the past. Tissue from your abdomen can also be used for reconstruction. There are many different types of abdominal tissue flaps described primarily by their blood supply, including the SIEA, DIEP, muscle-sparing free tram, and free tram. In general, tissue, sometimes including muscle, is taken from your abdomen and moved to your chest for reconstruction of the breast. The blood supply is disconnected at the abdomen and reconnected at the chest through the use of a microscope. This type of reconstruction most commonly does not require an implant. After surgery, you will have a scar hip to hip along the abdomen, around the belly button, and a patch of skin on the chest. Abdominal tissue is the most natural appearing reconstruction and is less likely to require surgery for symmetry if you are only reconstructing one breast. Choosing the right surgery for you requires discussion between you and your surgeon. The need for postoperative radiation will play a role in your first decision-making step. In general, if it is known or suspected that you will need postoperative radiation therapy, it is strongly recommended that you begin with tissue expander reconstruction. If it is known that you will not need radiation therapy, the decision regarding initial reconstruction surgery is guided more by other factors, including individual preference. Radiation therapy leads to tightening of the tissues. This causes breast reconstructions to appear higher, tighter, and smaller. Preoperative and postoperative radiation both have this effect, and postoperative radiation will have this effect on all types of reconstruction in place. Complications from radiation on reconstruction can be solved by tissue reconstruction, and approximately 40 to 50% of patients who have had pre- or post-operative radiation therapy will require tissue reconstruction after radiation is complete in order to adequately address and correct changes related to radiation. In our approach to reconstruction, therefore, we like to ensure we are prepared for radiation changes by having as many tissue reconstruction options as possible available to us after radiation is completed. In approaching the initial reconstruction decision, we know that if tissue reconstruction is performed before radiation, we will have more limited tissue reconstruction options available to us should radiation damage occur. On the other hand, if we choose tissue expander reconstruction as our initial approach, we have all tissue reconstruction options still available to us should radiation damage occur. Choosing the right initial approach for you then requires discussion and knowledge regarding your individual needs, with heavy emphasis placed on your potential need for radiation therapy. By prioritizing radiation in our decision-making approach, we put you in the best place for an optimized breast reconstruction outcome after all treatments are completed. This chart will be provided to you during your initial consultation with us. It covers major educational points regarding each of these types of reconstruction discussed. If you'd like to learn more about one of the particular surgeries, please view our additional presentations.